And one example that I'll show you, in which there's a nice timing because it became public this week, a paper in PNAS that you have received. It's a little particle, a membrane-coated particle, which a colleague of mine, Gunnar Rundqvist, now a pensioner, found in seminal fluid, in ejaculate. He found it 30 years ago in tremendous concentrations, and it turns out that it's being produced by prostate cells. They're pumping it out in seminal fluid, and it's needed for the health of the sperm and for the sperm to be successful in the woman's body. Now, his idea early on was that, well, if you start having invasive growth, if some of your prostate cancer cells don't live next to the channels that are the outlet for seminal fluid, but rather invade tissues, then these prostasomes will arise in higher concentration in interstitial fluid instead, between the cells, and they can be taken up in blood. So his idea was that they might be good markers, but he was never able to demonstrate that because he couldn't detect the levels in blood. So my colleague Masoud Kamali Moghadam, he devised a version of the assay that I just described. We capture prostasomes with an antibody, but then we don't use just 2, as I showed you before, but actually 4 more antibodies looking at different proteins on the surface. It's rather an extreme assay. If all these 4 bind together, then their attached DNA strand can be guided to be joined together, giving us a DNA reporter, which can then be amplified. And that turns out to buy us the sensitivity we need to measure the levels, both in normals and controls. And this was one small study he did in normal men and in men with prostate cancer. And there's a dramatic difference in the levels. He then repeated that in another group and confirmed that this could distinguish patients and controls. And if you now plot the levels according to how once you proceed to actually operating on these patients, you get a histological measure of the degree of malignancy. And as you may know, prostate cancer is a very heterogeneous disease. Some patients are probably left alone. They will surely die from another disease because the tumor is not going to be very invasive or metastatic. And others are very aggressive. And the way to measure that is by histologically identifying a Gleason score. So here we divided the patients according to what the Gleason score was upon operation. The samples were taken before operation, of course, the blood samples, but after operation we had a histological measure. And as you can see, this level 6, which is the maximal tolerable level, that's probably something you should leave alone and not operate upon. They have lower levels, whereas the 7 and above have higher levels. So we're able to distinguish the less harmful and the more harmful form of prostate cancer. This is a current assay which everybody loves to hate. It's actually doing quite a lot of good. We find a lot of prostate cancer using it, but we also find patients who do not suffer from prostate cancer or have a very mild case. And as you can see, there's no information here. This has to be repeated in a much larger study. I put in also this little diagram out of a science report just a few weeks ago describing the incidence, that is the diagnosis of prostate cancer and the deaths in prostate cancer. And the black here is the death rate. It's decreasing a little bit. We're making some headway, but not very impressively. But we have a tremendous increase, and there was this peak, and that is a peak when PSA was introduced. It was a tremendous increase in diagnosis of prostate cancer. So I think it nicely illustrates the kind of biomarkers that we will see in many ways. They will be more complex than the biomarkers we've looked at before in many cases. They will be expressed at very low levels where we will not be able to see them. We will need to look at many of them, but hopefully they could allow us to diagnose disease at early stages when we can still prevent the stages of the disease, the metastatic phases where we have little options, where therapy becomes very difficult. Something that is not at all supported by data, but just is a hope in the backs of our mind, is that we know that these exosomes, as they're called, prostasomes, are examples of something called exosomes, these membrane-coated particles. We know that they are produced by other epithelial organs, other organs that also suffer from cancer, like lung cancer, breast cancer, bladder cancer, and colorectal cancer, and so forth. So our hope for the future is to be able to identify the corresponding exosomes in these diseases and maybe turn this into quite a general screen for tumors anywhere in the body. But that, of course, is very far off and at this stage just a dream. So with that, I'll conclude my presentation.
Okay. Any questions from the floor? I guess something was mentioned earlier was that a lot of diagnostic tools we have, or you may be developing, are too subtle. When you look at sort of what's going on, particularly with some of the work you've done here with prostate cancer, when you're coming at from a research focus, do you think about what is the clinical question that this is going to answer at the end? Because what you really want is a doctor, do I operate or not operate, for instance? You need a simple yes, no. How much thought goes into that kind of when you start, or is it you start fishing and hopefully come up with something at the end?
Yeah, well, me personally, I have a slight background. I wouldn't trust myself as a doctor, but I have been working in surgery and gynecology for brief periods of time. However, part of the idea with SciLifeLab, again, is to really bring people together with very basic expertise, and Gunnar would be a representative of that area, and have them really communicate with the clinicians and identify what are the pressing problems and how can we work together. And there'll be a learning experience, but bringing them together, I think, is going to be really important. As it concerns myself, I'm working at something called the Rudbeck Laboratory, which is a translational center in Uppsala. We have clinical departments, so we have many clinicians, so we see patients there, but we also have more basic research ongoing in the same building and working quite intimately together already. So I think that will be the key. And certainly our aim is that these methods should not just be something that a mountain you climb once and show that you could actually do it, but never again, it's too difficult. But turn this into routine tests and maybe even to point-of-care tests that you could do very simply. And I think there is nothing in what we're doing that prevents it from actually being turned into a very rapid and simple test.
It sort of touches on the whole idea of trying to translate, from the advances in research into useful, actual useful technologies. And maybe, is there an element that, in sort of part of the innovative side of research, is there enough of a good balance between the actual research and then people actually taking a step back and seeing actually what does all this data mean and how can we use it? And is that maybe is the balance right? Do you think?
Right. Well, the operative word is balance. So, I mean, there's always going to be discussion, and I think more basic scientists are always concerned that we are putting too much emphasis on identifying things that in 5 or 10 years will be possible to give to patients, which would be a great risk. We should do things that will take even longer or much longer to develop. In our case, I think the tools we develop are going to be helpful for basic research, but they can also be turned around and used clinically with a lot of further development because they have to be simplified before then. So I think it's helpful to have a perspective. What could this possibly be used for? But if you can't really answer that question, but you can tell that this is really fundamental for understanding, then that's also certainly a valid reason for conducting the research. In our case, again, we have, as I mentioned, we're working sort of both at the borderline between more basic research, technology development, but also clinically applied. But we also have a further border to industry, and that's going to be another, I think, factor of success if we can very efficiently, and I think the further two speakers will tell you how to take things from basic research and apply it industrially. And we really need that. It's not possible to travel a technology from a basic research lab directly to another basic research lab. We need commercial outputs. In our case, we've spun out a number of companies, 5 companies over the years, and we're working intimately together with 3 that are closely located. That is also a balance, an ethical balance, if you will. But I think we are steering a steady course and benefiting both organizations.
There are at least 2 major pharma companies who are trying to put their prostate cancer drugs back into a preventative indication. Does your differentiation between recent schools 6 and 7 help their endeavour, because the PSA part of the indication didn't really do that?
Yeah.
Been rejected.
Again, this was a very small number of patients. It was around 100 or so. So much remains to be done. We need to confirm it. The assay has to be made more robust and so forth. But that's certainly one of the goals, to identify who needs the therapy and how can you best treat the patient. Not yet, no. I don't think they may have become aware of it now. We are, as I said, we have a very extensive interaction with biotech companies and pharma companies around the world. AstraZeneca is using our technologies and many other drug companies via our the company. But my lab has a collaboration with drug companies. But in the area of prostate cancer, we have not yet made any contacts. Please tell them.
Well, when you look at this technology, particularly some fancy new protein detection technologies I've seen over the years, it kind of requires new instrumentation that everybody's going to have to buy in order for it to be implemented. When you look at your technology, could this run on systems that are already in clinical labs today?
It can, but what we're mostly using as a readout is real-time PCR, which I think is pretty much in all labs by now, not so much in clinical labs. The next generation sequencing is getting there, or at least big centers certainly have lots of them. So I think that's also going to be a very powerful way, particularly for biobank type applications where you're not in a hurry. They are kind of slow, but eventually you get the information and you get lots of it. So for research purposes, I think sequencing is a perfectly valid approach, and that technology is also developing and becoming much simpler. The ion torrent machine takes 2 hours to sequence instead of a week or so.